Hello, tonight's video is about reflux. There are two kinds of reflux, and reflux literally means things that are going backwards, liquids in this case. The most common that we talk about is gastroesophageal reflux, which means from your stomach to your esophagus. And there's another kind, vesicoureteral reflux, which is when urine can go from the bladder up to the kidney, and that can be significant at times. But what we're going to focus on right now is the kind from the stomach to the mouth. And in newborns, this is very common, and this is a topic that pediatricians cover multiple times in any given regular day. Let me explain what happens after the liquid's swallowed. So the baby is nursing or taking a bottle, swallows the milk, goes through the throat, down the esophagus, and then through a little small circular sphincter muscle at the top of the stomach called the lower esophageal sphincter, or LES. Well, in a newborn, the tone of that little muscle is intermittent. It may be strong and then weak and floppy and flabby, and so anything that's gone down to the stomach can easily come right back up. And I used to have a gastroenterology professor who said babies are like gravy boats. If you tip them over, everything pours out. And that's because of the low tone in that lower esophageal sphincter. And so a lot of parents are almost surprised and say, I think my baby has reflux. So I want to tell you now, no, your baby does have reflux, because all babies have reflux to some extent because of that low tone muscle in there. It's common, they typically outgrow it, and it's not usually a source of stress for us, but it is very messy and it's a huge source of stress for parents. So I want to teach you the difference between the common and harmless kind of reflux and the more dangerous things that can happen. If you follow the milk all the way down, mouth, throat, esophagus, through the LES to the stomach, well, just after that is the pylorus, which is another strong muscle at the base of the stomach. Something that could happen that could be more dangerous typically is around a 3-week-old infant, most often firstborn, most often male. But that's not always the case. That muscle, the pylorus, can become very hardened, enlarged, hypertrophied, and then it doesn't allow any milk to pass through the stomach. And in that case, the milk that comes back up, it isn't just an effortless splash, just a fountain. It's a forceful, retching, projectile vomiting. And with that, none of the milk's able to go through, so the baby suddenly has decreased urine output, decreased stool output, so it's a very different thing from just reflux. So spitting up is extremely common. Babies have tiny tummies. When they're first born, they can only handle about a teaspoon of fluid, which fortunately is what most moms make in their colostrum, so it's still extremely important that the baby nurses and suckles very frequently at the mom's breast early on to stimulate her milk supply. The colostrum helps get everything moving, including the meconium. But then as the maternal breast milk comes in by around day of life 3 or 4, the baby's suddenly getting larger volumes of milk at a time. And most of the time at that point, they can handle about an ounce, ounce and a half, 2 ounces. If they drink much more, they'll probably spit it up because they can't hold it down. So I want to reassure you that that's not dangerous and it's not harmful to the baby. When I was in training over 20 years ago, we always taught parents, and we were taught that reflux is simply physiologic. Babies will outgrow it, and they typically do outgrow it between 7 to 9 months as they spend more time upright. Remember, a newborn is on a completely liquid diet, and they're lying flat on their back all the time. I think even most of us would reflux if that was the case. So that's part of the problem, and because their entire diet is so thin in consistency, it's harder for it to stay down. So we try to reassure parents that as long as the baby's gaining weight, it's not truly a disease process. Well, then after we thought it was just normal physiologic over 20 years ago, maybe 10 to 15 years ago, it became more common to think of it as a disease process. And so people began to treat it very aggressively with medications. There are a couple of medicines that we use now, and you should know that now the pendulum has sort of swung back to, well, really this is physiologic. Babies will outgrow it as long as their growth curves look good and their weight gain's impressive. We're not really concerned about it. It's just very messy. So now we try to limit the use of medications. As studies have shown, the medicines don't actually decrease the number of episodes per day of spitting up. And so that helps some parents understand we're not actually fixing this problem, because the problem is that low tone muscle, the lower esophageal sphincter, and none of the medicines in the world so far can make that muscle have more strength. So yes, we will occasionally use medicines. The most commonly used one is ranitidine, which is the formerly known as Zantac, was the brand name. It is generic, it is prescription. It does not taste that great. The babies don't act like they like it, and it's given twice a day. Again, it's not going to stop the total number of episodes really or impact it at all, but it may decrease somewhat the acid production in the baby's stomach. Now, there is another whole category of medicine called proton pump inhibitors, or PPIs, and the most commonly used ones of these are Prilosec or Prevacid, that group. We used to use these a lot more often than we do now, as one of the GI groups have now recommended we be less aggressive in treatment of reflux, because as I said, this pendulum swung back to we just think this is physiologic now. There are some other things you can do though, what we call supportive care measures. If you think about it, if your baby has swallowed a lot of air during the feeding, which is common, and this big gas bubble is coming up through the esophagus, it may bring up a lot of milk on top of it. So we try to burp the babies frequently during the feeding, and that can help, we think, a little bit with the spitting up or the reflux. We try to keep the baby's head elevated, keep them upright for at least an hour after feeds. That is simply trying to get gravity, help us hold that milk down better so they won't bring as much of it back up. Another supportive care measure is to thicken the feeds. So if you think about it, the thinner the liquid, the easier it is to reflux back up. If we could thicken that feed, maybe it'll stay down better. When we do that, there are a couple of pros and cons here. Thickening the feed actually has been shown in studies to keep more milk down, maybe a 50% improvement at most. So what we would do is use 1 teaspoon of a stage 1 cereal like rice or oatmeal for every ounce of expressed breast milk or formula. Now obviously if the baby is contact feeding on the breast, there's no way to do this, but if you wanted to do maybe a bedtime bottle with pumped milk and add the rice cereal, you could try that. Couple of caveats though. When the milk is thicker because of the added cereal, it's not going to as easily go through the holes that are in the artificial nipple, so you may have to enlarge those holes a little bit. The other problem is sometimes if the milk going in is thicker, their poops can be a little bit thicker too. So some babies can get constipated when you add the cereals. And also if you add the cereals very early on, babies are not as able to digest the carbohydrates, and it could make them gassier to increase their carbohydrate load in their feeds. Certainly, it could make babies obese to add the carbohydrates too. That's not usually a problem, and a lot of preemie babies or babies who need to gain more weight could actually benefit from some added calories in their milk, and that's not usually one of our concerns. I should also mention that this is not just a baby thing. Now, infants certainly are the most at risk for reflux and typically outgrow it as they get older, and they're eating solid foods and they spend more time upright and not lying flat all the time. But even in older children sometimes, and obviously you know in adults, you've probably experienced it as well. So if we have an older child that's complaining of burning in their chest, wet burps, a sour taste in the back of their throat after they burp, that's also reflux. But most of the time in older children, you can figure out a trigger that's made this happen. It may be high-fat, greasy fried foods, fast foods, caffeine. In adults, it could be alcohol, tobacco use. So for children, we would try to cut out caffeine and sodas, carbonated beverages, extremely spicy or extremely greasy foods. And if an older child complains of these reflux symptoms just periodically, maybe once a month, we would just use a Tums. They're completely harmless. They're an acid neutralizer. They're just a base, calcium carbonate, and that can give them symptomatic relief. If an older child's frequently complaining of these symptoms, we can start them on Zantac as well, which for the older kids is now over the counter. So that's pretty easy to do. So I hope this explains to you that we are not afraid of reflux as long as the baby has good weight gain. And this is a good time to remind you, everything I've tried to explain is general medical information and advice and never pertains specifically to your individual baby. As always, please consult with your child's pediatrician and look at those growth charts and look at the percentiles and make sure the weight gain is still good. Because if it is, the reflux is messy, but not dangerous or scary or alarming.